Now we're going to talk about the pathophysiology of malignant hyperthermia. This is basically a drug-induced hyperthermia in hospital setting among patients with genetic defect of ryanodine receptor channels. This is basically autosomal dominant mutation, and the causes of malignant hyperthermia are halogenated anesthetics and muscle relaxants. So these anesthetics include halothane, isoflurane, enflurane, desflurane, and muscle relaxants include succinylcholine and caffeine. In these individuals can also cause malignant hyperthermia. So what's the mechanism? So causative drug binds mutated ryanodine receptor channels, and that increased calcium release from sarcoplasmic reticulum. In turns result in increased muscle contraction, and that increased muscular contraction increases heat generation due to ATP hydrolysis. And this increase in heat generation causes increase in metabolic rate to replenish that energy, and that increase in metabolic rate increases in O2 consumption and CO2 production, and you have increase and predominant increase in CO2 production in malignant hyperthermia, and that leads to tachypnea, to acquire more O2 and exhale CO2. So increased muscular contraction along with hyperthermia breaks muscle cells, and that releases potassium from the muscle cells, that releases myoglobin from the muscle cells, and creatine kinase. Increase in potassium release causes hyperkalemia, which reduces potassium efflux out of cardiac myocytes due to decreased concentration gradient. So basically hyperkalemia, there's too much potassium outside the cell, and basically no potassium or less potassium can leak out due to less concentration gradient. So more potassium stays inside the cell, and cell become positive, which is more likely, that cell is more likely to depolarize initially, causing arrhythmias, bradyarrhythmia to be specific, and then later on those slow potassium depolarizations inactivate sodium channels, which decrease depolarization and block conduction pathways, and this is called the process of accommodation, which later on causes asystole and heart stops pumping. Then you have myoglobin from muscle breakdown, that's called rhabdomyolysis, and that increases renal damage as well. And since myoglobin is acidic in nature, you treat with sodium bicarb. Increased skeletal muscular contraction increases anaerobic metabolism, that causes lactic acidosis. So patients come in with patients can have lactic acidosis in there. Hypermetabolism also causes cellular hypoxia. That also adds up to that metabolic acidosis. So there are multiple symptoms or signs and symptoms occurring, and these are all the mechanisms behind those signs and symptoms. For treatment, you stop the causative drug, cool the body, and give dantrolene, which blocks excitation contraction coupling between T tubules and sarcoplasmic reticulum. And for the next surgery, you can use nitric oxide.